Back to our channel. Today, let us start the respiratory physiology revision series. So, first, let us start with the structure, function, relationship in lungs. So, mainly respiratory physiology involves lungs and its airways. So, let us see the airway arrangement. So, the largest is the trachea. It progressively divides into alveolar sac, and branching can also be referred to as generation of airways. So actually this generation of airways was found by Weibull, so it is called as Weibull model, that is it has mainly 23 generations. So let us see what are those 23 generations. The first 16 generations are conducting airways, which are also known as dead spaces. Conducting airways are like trachea, all those structures which are mainly which are not useful for gaseous exchanges. They are conducting the air towards the gaseous exchange site, so they are also called as dead spaces. So dead spaces means they are not useful for gaseous exchange, those are called as dead spaces. So the first 16 generations among the 23 generations are the dead spaces, whereas the last 7 generations are the alveolar airways, which are also known as respiratory exchange airways, because here the exchange takes place, here the actual exchange takes place, so these are called as alveolar airways. Next, let us see the conducting airways. So conducting airways, the first 16 generations. So mainly the conducting airways are, as we discussed, there are 16 generations. So the lining epithelium of these airways is mainly pseudostratified ciliated columnar. We already seen this in histology, right? So remember, pseudostratified ciliated columnar. They have cilia because any mucus or any dust particles or any bacteria, if it comes, they can avoid it by their cilia mechanism. So cilia movement mainly causes the outward movement of sputum, as we discussed just now. The cilia movement is synchronized metachronism, means it is a synchronized movement which is mainly required for the transport of the sputum away from our throat into nasopharynx. And cilia movement requires dynein. Dynein is a special protein which is required for the movement of cilia, and the cilia movement functions are mainly protective, like to clear the sputum, and development, rotation of internal organs. In the development, coming to embryology, rotation of major organs, like for example heart. In heart rotation also we need cilia in an embryonic time, right? So this all are the functions of cilia. So if the dynein is absent, then the cilia becomes immobile. So dynein is very important protein which is useful for the mobilization of cilia. So if dynein is absent, completely cilia will become immobile, and immobile cilia syndrome is formed because of this. That is also called as Cartagener's syndrome. So Cartagener's syndrome is an immobile cilia syndrome. So here what happens in this syndrome, the cilia will not move. So next, there are triad features related with this Cartagener's syndrome, that is sinusitis, bronchiectasis and situs inversus. So why sinusitis is formed? Because here now the cilia are not able to move, so it is not able to clear the sputum, so it leads to sinusitis and bronchiectasis and also situs inversus. So because in development phase the rotation should take place, but because here the rotation may not take place, so it may lead to situs inversus. And we also have some additional features like astenospermia, leading to infertility. Cilia is also useful for movement in it is also useful for fertilization, but here as they are absent, it may lead to astenospermia. So if the dynein is present, cilia and cell are normal, but still the cilia is immobile. So till now we have seen a case like the dynein is absent, so because of absence of dynein, cilia is immobile. But there is also another case like here everything is normal, but still the cilia is immobile. So the case here is mainly because of thick and sputum. If the sputum is thick, very much thick, so if sputum is thick, you can understand this thickened sputum, the cilia are very thin, they can't handle this. So because of this also sometimes there may be failure, like especially in cystic fibrosis. In cystic fibrosis the main problem is thickened sputum. So because of this thickened sputum, the cilia are not able to move this, that's why they are immobile here. So CFTR is a gene mutates, then the cystic fibrosis transmembrane regulator. So actually we have a gene called CFTR. This CFTR full form is cystic fibrosis transmembrane regulator. So this mainly regulates the movement of cilia. So even if this gene gets mutated, then we may have this kind of cilia immobile syndromes. So CFTR mainly regulates the opening of chlorodiol channels. So we are saying it's regulating. What it is regulating? Mainly it is regulating the opening of chlorodiol channel. So the treatment is mainly chloride channel opener. So now we need to open the channel because of the CFTR mutations the channel is blocked. So to open this we may give some drugs like you can see Ivacaftor. So you can here in this drug also you can see the name CFTR. You can see here CFTR. So by this also you can remember that Ivacaftor is mainly used for the CFTR gene mutation mainly to open the chloride channel. So it contains stem cells. So actually in respiratory system we also have some stem cells, mainly these are of two types which aid in lung regeneration. You know stem cells are always useful for the regeneration. So mainly there are two types of stem cells like basal cells and Clara cells. So these are mainly useful for the regeneration of whole lung. So unique features seen exclusively in conducting airways is smooth muscle lining. So you can see the smooth muscle lining only in the conducting airways, whereas in respiratory airways you can't see the smooth muscle lining. So especially when a person is exposed to cold temperature or dust particles, the bronchoconstriction takes place. So this is very important. You know the smooth, just now we are saying in conducting pathways only the smooth muscle is present. So whenever a person is exposed to cool air or particles, dust particles, then this smooth muscle around the conducting pathways make them to constrict, they come nearer. So because of constriction the lumen is narrowed. So to counter the bronchodilation so in a vasoconstriction actually the resistance increases and also the airway passage of airway decreases. So to counter this we will do the bronchodilation. Bronchodilation is just like a treatment for this. So bronchodilation mainly decrease the resistance, so the airflow is increased. When the resistance is decreased, the airflow can easily flow to this, and bronchodilation may also increase the resistance where the airflow is reduced. Actually bronchoconstriction increase the resistance, bronchodilation decrease the resistance. So this should go here. Bronchoconstriction increase the resistance, in turn decrease the airflow, whereas bronchodilation it decreases the resistance and increase the airflow. So now let us see the bronchoconstriction and bronchodilation, some differences. So mainly let us first discuss about bronchoconstriction. So bronchoconstriction, the main important one which causes in the autonomic nervous system is our parasympathetic system. In heart it is reverse. Parasympathetic nervous system in heart, it decreases the heart rate, whereas here you can see and also parasympathetic nervous system is like opposite effect in the case of our vessels also, because in vessels the vasoconstriction is done by sympathetic nervous system and vasodilation is done by parasympathetic system. But here in the case of our lungs it is different. Bronchoconstriction is done by parasympathetic nervous system, so mainly by releasing acetylcholine. So acetylcholine we know it is cholinergic. It is a metacholine which causes a bronchoconstriction. So remember acetylcholine from parasympathetic causes bronchoconstriction, and anticholinergic is like ipratropium which causes bronchodilation used in the treatment of asthma. So mainly we are saying bronchial asthma, right? Actually what is the cause behind the bronchial asthma? That is the bronchoconstriction, so which is caused by parasympathetic nervous system. So here the treatment is like we can give the ipratropium. So even histamine, we have another one, histamine. You can see histamine is actually a vasodilator coming to vessels, whereas here you can see histamine is a bronchoconstrictor, and leukotriene is also cause the most potent bronchoconstriction. So let us revise. The bronchoconstrictions are mainly because of parasympathetic nervous system which release acetylcholine. Acetylcholine is cholinergic which leads to bronchoconstriction, and also we have the treatment as ipratropium which is an anticholinergic which is also used in the treatment of asthma, and we have histamine and leukotriene. So leukotriene also most potent bronchoconstrictor among all this. So leukotriene, remember. Next coming to bronchodilation. So you can see bronchodilation is mainly by sympathetic nervous system. Here we have beta 2 receptor agonists like salbutamol. Salbutamol is used here. It's like beta 2 receptor agonist, and also nitric oxide. Nitric oxide is a dilator even in our vessels, even in our broncho. Here also nitric oxide is a dilator. And VIP, what is this VIP? It's a vasoactive intestinal peptide. So this is a non-adrenergic and non-cholinergic, because non-adrenergic is neither sympathetic nor parasympathetic, because non-cholinergic is parasympathetic, nor adrenergic is sympathetic. So it is neither of them. Nancy, it is Nancy, it is VIP. So VIP, nitric oxide and beta-2 receptor agonist, salbutamol, all this cause of bronchodilation. So even salbutamol also can be used in the case of bronchial asthma because it's a bronchodilator. As in asthma it is bronchoconstricted, we can use even salbutamol, and also we can use ipratropium. So these are the drugs which can be used for the bronchial asthma. Now let us start with alveolar airways. So alveolar airways are the non-conducting pathways, means where the real gaseous exchange takes place. So these are mainly useful for ventilation, the exchange of gases in the last 7 generation of airways, because we have seen total 23 generations. Among them 16 generations are conducting, whereas 7 are non-conducting, or the actual airways where the gaseous exchange takes place. So now we are talking about that last 7 generations. So the technical term for the cells found in the alveolar airways is mainly pneumocytes. So as the name itself, you can see lungs, that's lung cells, pneumo, it's related to lungs, and these are the actual lung cells. So here we give the name as pneumocytes, whereas in that last 16 generations we can't give, because they are the just dead cells, or like dead spaces, like only they are conducting ways but not the actual exchange sites. So these are the actual exchange sites, so these cells are called pneumocytes. So pneumocytes are divided again into 2 types, type 1 and type 2. So type 1 are large size cells and they cover the large surface area. This is very important. They are large size, so as they are large size they can of course cover the large area. Whereas type 2 cells are surfactant cell, very important. Surfactant is produced by type 2, and also type 2 cells sometimes can act as even stem cells, and they are small in size but more in number. So this is the difference. Type 1 cells are large and occupy large area, whereas type 2 cells are small but more in number, and also they are acting mainly as surfactant and also stem cells. So now let us see the surfactant. So surfactant appears 28 to 32 weeks of gestation in the gestation period, and the structure mainly it contains lipids and proteins. So proteins is a surfactant protein, like surfactant protein A, B, C, D. There are 4 types of surfactant proteins, whereas lipids, major we have lecithin here, and minor we have sphygmomyelin. So lecithin is in turn having DPPC, that is dipalmitoyl phosphatidylcholine, and the minor one is sphygmomyelin. So surfactant is made up of both lipids and proteins. So 4 types of proteins, 2 types of lipids, major and minor lipids. So clinical use of this surfactant is mainly to assess the fetal lung maturity. That is, you can see we use it as L by S ratio. L by S ratio here is lipid by sphygmomyelin ratio if it is greater than 2, and the bubble shake Clement test is used in amniotic fluid, which forms bubble on shackle if it contains surfactant. So actually for example, if you take a small test tube, for example let us think this pen as test tube, right? So if you take this test tube, in this you put the amniotic fluid and you add some substances. So finally if you shake it, after shaking, if the bubbles are formed, then we can confirm that the lipids are present in it, and if the lipids are present in it, we can say that the surfactant is present in that particular baby. That is, the lung has matured. If the lung has matured, only the surfactant is present. So this shaking test, this Clement, why the name Clement? The scientist has found this. So the Clement test, all these are mainly used to confirm whether the surfactant is present or not. So we also have lamellar body counting. Actually, the storage bodies, lamellar bodies are formed here. Even by counting them, we can confirm the lung maturity, whether the surfactants are present or not. So these are all the tests which are used to find out in a fetal life whether the surfactant is still formed or not. That is, whether the lung has matured or not. So now let us see the function of surfactant. So function, the lower surface tension to mainly prevent the collapse of alveoli and the stability of alveoli. Surfactant is used. So they have the role in lung immunity. So mainly the surfactant A and surfactant D, as we said, for surfactants or proteins are of 4 types, right? So among them, the surfactant A and the surfactant D have the role in the lung immunity. So these are the main functions of surfactant, like they give immunity and they prevent the collapsing of the lung, right? So let us see the Laplace law. So the Laplace law says that 2 into tension is equal to pressure into radius. That is, this is a physics formula. Now let us convert into physiology. That is, surface tension is equal to collapsing pressure. Collapsing pressure into radius of alveoli. So what is saying? Surface tension is equal to collapsing pressure into radius of alveoli. So the main role of surfactant is to decrease the surface tension. So by decreasing the surface tension, we can also decrease the collapsing pressure, and in turn leading to the increase in the radius of alveoli, and the surface area of alveoli is increased, so that more gaseous exchange can take place very easily without any collapse of alveoli. So that is the main reason of the surfactant. So surfactant is mainly produced by type 2 pneumocytes, and they form the lamellar bodies and storage bodies for the surfactant. Lamellar body containing for assessing the fetal lung, which is used for the assessing the fetal lung maturity. We already seen the test lamellar body counting, right? So regulation, actually what this surfactant does, it mainly increases the surfactant production. And steroids, what are the substances which increase the surfactant production? Mainly they are steroids. So steroids are the corticosteroids like cortisol. Treatment is given like drugs which are given in a pattern of babies with immature lungs to increase the surfactant. Sometimes some babies are formed with less surfactant with increased surface tension. Then in that babies we need to give surfactant treatment by the drugs which are similar to it, so that we can increase the surfactant and thereby decrease the surface tension. So the drugs are like betamethasone, dexamethasone, thyroid hormones like T3, T4. So these are the things which we need to give to the baby if the surfactant is low. And decreased surfactant production, decrease in surfactant is always pathological. Excess level of insulin also causes decrease in surfactant. And gestational diabetes mellitus, like infant of diabetes mellitus mother, higher amount of insulin mainly also decreases the surfactant. So the mothers who are like having diabetes and they're giving birth to the child infant who is also having lot of insulin, so because of this also the surfactant in that baby may be decreased, right? So due to increase in insulin, so decrease surfactant due to increase in insulin, and that lead to respiratory distress syndrome or hyaline membrane disease. So actually hyaline membrane disease is mainly due to this insulin increase, that too in diabetes mellitus mothers. And the treatment is surfactant drugs. So the surfactant drugs are like lucinactant, benactant. So you can see their names also like actant, like surfactant. So like that easily you can remember them. Lucinactant, benactant. So this is all about our beginning introduction of our respiratory physiology revision series. Let us see some MCQs like which will increase the airway resistance. Actually we need options, right? So respiratory distress syndrome is mainly due to deficiency of type 2 pneumocytes or surfactant, right? And the surfactant production is accelerated by steroids, glucocorticoids, and also what else? We have discussed thyroid. Even thyroid can increase, and what can decrease? Increase in insulin can decrease, right? So these are all the things to remember mainly about the introduction. So let us see the next section. Let us continue the next session with mechanics of breathing. Continue our revision series of respiratory physiology with the mechanics of breathing, coming the second one. So actually here we have the Boyle's law. So actually what Boyle's law says, that the pressure of gas is indirectly proportional to the volume of gas. That indirectly means that the volume and pressure are inversely proportional. So in physiology, the V here refers to the tidal volume of 500 ml of air, whereas P is the mainly the intrapleural pressure. So the intrapleural pressure at rest, that is, you can shortcut it into IPP. IPP is negative, like just minus 2.5 millimeters of mercury, and this IPP becomes positive only during the forceful expiration. So this is very important. IPP is always negative, it becomes only positive during forceful expiration. So why IPP is negative at rest? Let us check out this. So the normal tendency of chest wall is to move out. You can see this is the chest wall, it always tries to move outward, and the normal tendency of the lung is always to move inward. So you can see lung always tries to move inward and the chest wall always tries to move outward. So pleura is present between the lung and chest wall. You can see this is the lung, this is the chest wall, in between them we have the pleura. So hence pleura is like facing the two opposite forces. Like you can see this side of the pleura, actually pleura is divided into visceral pleura and parietal pleura. So parietal pleura is always forced by the opposite force of chest wall, and the visceral pleura is always forced by lung. So both you can see they are pushing in opposite direction. So because of this, in between this pleura a vacuum is created, and always the pressure inside the vacuum is negative. So hence the intrapleural pressure is always negative. So you can see here the vacuum is created in between and the intrapleural pressure is negative. So So here we have IPP changes, means intrapleural pressure changes during inspiration. Let us see how it changes. So the volume increases. Actually, this is also according to Boyle's law. You can always understand during inspiration our lung volume is increased, means lot of air now we can accommodate inside, means volume is increased. So by Boyle's law, if volume increases, of course intrapleural pressure decreases, because both are inversely proportional. And also not only that, you can also understand it like whenever your intrapleural pressure is negative, it sucks more air from outside from atmospheric pressure, so that the intrapleural pressure also decreases by Boyle's law, like 6 millimeters of mercury or 8 centimeters of water. So the intrapleural pressure is 6 millimeters of mercury or 8 centimeters of water. So intrapleural pressure changes during expiration also. This is the reverse. The volume decreases here during expiration and the pressure increases to like -2 to 5 millimeters of mercury. So now let us see the alveolar pressure. So alveolar pressure is nothing but the pressure which is present in the alveoli. So the resting alveolar pressure is 0 when no air enters or leaves the alveoli. According to Boyle's law, during inspiration the volume increases and alveolar pressure decreases, same like intrapleural pressure, right, by 1 millimeters of mercury, and at the end of inspiration alveolar pressure becomes 0. This is very important. So actually what happens, always either at the end of inspiration or either at the end of expiration, always the alveolar pressure comes to the 0, but only at the beginning of inspiration the alveolar pressure becomes more negative, and at the beginning of expiration the alveolar pressure becomes more positive. These are the features we need to remember. So you can see during expiration the volume decreases, the alveolar pressure increases by 1 millimeters of mercury, and at the end of expiration again the alveolar pressure comes to 0. So these are very important. At the end of inspiration and at the end of expiration, always the alveolar pressure comes back to the 0. Now let us see the transpulmonary pressure. So the transpulmonary pressure is alveolar pressure minus pleural pressure. So you can easily remember it like a short form TAP. TAP means transpulmonary pressure is equal to alveolar pressure minus pleural pressure. So here at rest, the transpulmonary pressure, actually alveolar pressure is 0, whereas pleural pressure is -2.5, it's negative. So negative plus negative, it becomes positive. So plus 2.5 millimeters of mercury is the transpulmonary pressure. So actually the transpulmonary pressure is a type of distending pressure. Distending means dilating pressure. It's a bronchodilator. So pressure volume change during breathing. So actually mainly during inspiration the volume increases. That's what we are saying from long time. And the intrapleural pressure is -6 milliliters of mercury, and the alveolar pressure is -1 milliliters of mercury. So this is all going on during inspiration. So during inspiration volume increases, intrapleural pressure is -6 and the alveolar pressure is -1, whereas during expiration the volume decreases and the intrapleural pressure is -2.5. So you can compare it with inspiration. You can see inspiration intrapleural pressure -6, whereas expiration intrapleural pressure -2.5, and the alveolar pressure you can see plus, whereas here it's negative. So during expiration it's positive and during inspiration it's negative. Now let us see the muscles of respiration, mainly the inspiratory muscles and expiratory muscles. So the inspiratory muscles, actually during rest, the inspiratory muscle mainly is our diaphragm, whereas the accessory muscles which are useful, with forced inspiration we have external intercostal, scalene, sternocleidomastoid. So these are the forced inspiratory muscles, whereas coming to expiration, it's a passive process which is required for forceful expiration, mainly during exercise. So we have the rectus abdominis, transverse abdominis, internal intercostal. So these three muscles are mainly useful for forceful expiration, whereas for normal, always remember, for normal expiration it's a passive process, just the lungs recoil themselves and no need of any muscles. But in the case of forceful expiration like exercise, we need rectus abdominis, transverse abdominis, internal intercostals, and among them the rectus abdominis is the most important muscle for a forceful expiration. Next let us see compliance. So compliance is nothing but the distension, means the stretchability of the lung. So this is called as compliance, and the lung is considered like a spring. So lung is a spring with a high amount of distension. So opposing forces of the compliance are like surface tension, exerted by water molecules on the surface of alveoli majorly, and also elastic recoil, elastin. So those are all the opposing forces of compliance. Hence we say that compliance is inversely proportional to elastance. So whenever the elastance increases, compliance decreases, or whenever the compliance increases, the elastance decreases. So these both are inversely related. Now let us see emphysema. Emphysema, it's a condition which is mainly seen in smokers. So because of smoking, the elasticity of the lung is decreased. As the elasticity of the lung is decreased, now we know elasticity is inversely proportional to compliance. As the elasticity is decreased, now the compliance increases. So it's if the compliance increases, it's like a difficulty for these people. As the compliance increases during inspiration, it's very easy for them. Even with small air going inside, they have higher compliance. So inspiration is very easy, but expiration is very hard because their ducts are so much distended or restricted. So because of this, during expiration the air may not come out. So that is the case in emphysema. So X-ray finding is hyperinflation and compliance decreased in restrictive lung disease like pulmonary fibrosis, interstitial lung disease. So all of these cases where compliance is decreased. So here you can see compliance is decreased means elastance is increased in the case of fibrous diseases. So the normal compliance of lung is 200 milliliter per 1 centimeter of water. So compliance formula is change in volume divided by change in pressure. You can see delta V by delta P. It's a compliance formula. Whereas the elastance formula will be reversed. That is change in pressure by change in volume gives you the elastance formula. So now let us see the types of compliance. So mainly compliance is divided into three types: static compliance, dynamic compliance and specific compliance. So the static compliance, as the name you can see, static means not moving. So when you hold the breath, then it is called a static compliance. Coming to dynamic compliance, during breathing, airflow, resistance, impedance. So during breathing you can understand dynamic, it's moving. Whereas specific compliance, it's like compliance divided by functional residual volume. Now let us see the compliance curves and work of breathing, last part. So compliance curve, the relationship between inspiration and expiration gives you the compliance curve. So hysteresis, what is hysteresis? It's a direction of inspiration is opposite to the direction of expiration. Hysteresis is due to the surface tension forces. So you can see here, this is the expiration direction, this is the inspiration direction. So by this you can say the hysteresis is formed like inspiration is in one direction and expiration in the other direction, that is both are in different directions. This is caused mainly due to the surface tension forces. So because of surface tension, if the expiration and inspiration are in opposite direction, it is called as hysteresis. So compliance is greatest during expiration. In compliance of air filled lung, hysteresis is present. So compliance is greatest mainly during expiration, remember. And compliance of air filled lung, hysteresis is present. In saline washed lung, no hysteresis is seen. So here you can see this is the graph of saline washed lung. You can see saline washed, no hysteresis is seen. Saline removes the surface tension. So always you remember, because of surface tension only the hysteresis is formed. Here now we remove the surface tension, so there is no hysteresis. So hence the saline washed lung, no hysteresis. So compliance curve with three compliances, that is PL is a compliance of lung, PW is the compliance of chest wall, and PTR is the total compliance. So in this graph we can see those. Here PW is the compliance of chest wall. Chest wall always tries to move outward, so that's why it is towards this word. Whereas you can see here the PL, that is the compliance of lung. Compliance of lung is always towards inward, so it is towards this side. Whereas PTR is a total compliance. So total compliance in the middle. So it's a functional residual capacity in the middle which controls this inward and outward movements of chest wall and the inward movement of lungs. So the two opposing forces in the thorax balance each other. The balancing point or the equilibrium point is the functional residual capacity. So if the lung is completely collapsed, the pneumothorax, the minimum volume air is present. In pneumothorax actually what happens in the pleural space, instead because of stabbing wound or any other case, because of that the air enters into this pleural space. So that may lead into pneumothorax. It's a minimum volume air pressure. Air is present, minimum volume air present, and the lung collapse the lung completely in the case of pneumothorax. Now let us see the work of breathing. The work done to move air in and out of the lung is called work of breathing, and the work is equal to force into displacement according to physics. Now let us bring physics into physiology. So the force here is a pressure change in the lung, and here displacement is a volume change in the lung. So the normal work done by the lung is actually 0.5 kilometer per minute. So if the work done is 100%, then we divide this work into 65% and 35%. So the 65% work is a major work. To overcome elastic forces, it is divided into 2/3 and 1/3, 2/3 of surface tension and 1/3 of tissue elasticity, whereas 35% work done to overcome the resistance. Among that, 28 is airway resistance, 7% tissue resistance. So that's it, we have completed our revision fast quick revision series. But now let us discuss our important MCQs. So the first one is, several students are trying to see who can generate highest expiratory flow. So for the highest expiratory flow, which muscle is? So here the rectus abdominis is the most effective for producing the highest expiratory flow, and next comes the intrapleural pressure is negative because the chest wall is moving towards inside and the lung, the chest wall is moving towards the outside and the lung is moving towards the inside, that is both are opposite. So the inside pulmonary pressure is negative because the vacuum is created there. So that is the answer. So these are all related to our respiratory series of mechanics of breathing. Next let us continue our series. Back to our channel. Today let us continue our revision session of respiratory physiology. So we are in lung volume and capacity first. So actually lung volume is divided into two types of volume. One is static lung volume and the other is the dynamic lung volume. So in the name you can see static. Static means it's not dependent on time, it is time independent. So here we can take example as a tidal volume. You know the tidal volume is 500 milliliters, or you can say 1.5 liters, right? And coming to dynamic lung volume, it is a forced expiratory volume in the first second. So hence the name forced expiratory volume. Here 1 represents in the first second. So it is time dependent, hence dynamic. So remember, static lung volume is time independent, that is tidal volume 500 milliliters, whereas dynamic lung volume is the forced expiratory volume in the first second, that is time dependent. You can see in the name itself here, first second. So it is time dependent and it is mainly used for the diagnosis of respiratory disorders. So dynamic, D for D, that is dynamic for diagnosis. So dynamic lung volume is only used for the diagnosis, whereas tidal volume is not used. So that is one more important thing. So now let us see the static lung volume. The static lung volume, here you can see the tidal volume till here, and here. So tidal volume is like the air. Actually, you know, in our lungs we have always the residual volume, which is always present even if you do forced expiration or forced inspiration. So only the tidal volume, this 500 ml of air only comes in and out of the lungs, that is the tidal volume. And next, if you take the forced inspiration, then the inspiratory reserve volume, and if you take deep, you know, expiration, that leads to expiratory reserve volume. So in the deep inspiratory reserve volume you get 2 to 3 liters, whereas expiratory reserve volume is 1.3 liters. So you can see the inspiratory reserve volume is greater when compared with the expiratory reserve volume. Inspiratory reserve volume is 2 to 3 liters, but the expiratory reserve volume is 1.3 liters. So after the expiratory reserve volume also, after maximum expiration also, there is still the volume which is remained in the lungs, that is called as residual volumes, that is 1.2 liters. So these all values are very important to remember. So tidal volume is the volume of air which is moving in and out of the lungs during normal respiration. It is just 500 milliliters, whereas inspiration reserve volume is about the normal inspiration, the maximum possible inspiration. So this is a maximum possible inspiration, it is of like 2 to 3 liters. And next, coming to expiratory reserve volume, it's the point of maximum expiration. So inspiratory reserve volume is maximum inspiration, expiratory reserve volume is maximum expiration. So maximum inspiration is only greater, like 2 to 3 liters of air you can take in with the maximum inspiration. With the maximum expiration you can only expel 1.3 liters of air out of from your lungs. And next comes the residual volume. The amount of air which is remaining in the lungs as a residue even after the maximum expiration is called residual volume, and it's 1.2 liters. So always 1.2 liters of air is always remained in our lungs even after forceful expiration. So next, what is static lung capacities? So we have inspiratory capacity. You know, inspiratory capacity is equal to tidal volume plus inspiratory reserve volume, that is 2.5 to 3.5 liters in total. And the functional residual capacity is the expiratory reserve volume with the residual volume, that is giving 2.5 liters, that is a functional residual capacity. And next, coming to vital capacity. Vital capacity involves three components, that is the tidal volume, inspiratory reserve volume and expiratory reserve volume. Here the reserve volume is not included, so total is 3.8 to 4.5 liters. Next, coming to total lung capacity. So total lung capacity, in the name itself you can see it is total, so all components are added: tidal volume, inspiratory reserve volume, expiratory reserve volume and also reserve volume. So total we have 5 to 6 liters. So FRC is always equal to 50% of TLC. Means you can see here FRC means functional residual capacity, you got half, 2.5, whereas total is 5. So you can see FRC is half is equal to 50% of TLC. that is functional residual capacity is half of total lung capacity. So 50% of TLC is known as equilibrium point, also called as midpoint, that is 2.5 liter FRC. So next, coming to closing capacity. So what is closing capacity? The closing volume. So the volume of air which is enclosed by basal region of lung dependent part towards the end of expiration. So at the end of expiration, how much of air is present in the basal part of the lung, that is called as closing volume. So closing capacity is equal to residual volume plus closing volume. So remember, closing capacity is equal to residual volume plus closing volume. Closing volume is nothing but the amount of air still which is left in the base of the lungs. So spirometry can't measure. Actually, we you know to find out this all capacities we use spirometry, but spirometry can't measure the residual volume, functional residual capacity, and the total lung capacity. Why? Because as you know, residual volume, it is first basic thing is the residual volume. If the spirometer can't only measure the residual volume, you know, functional residual capacity involves the residual volume and expiratory reserve value. So if the residual volume is involved in it, so we can't measure it. And even in the total lung capacity, you know, residual volume is involved. So these three, mainly residual volume, functional residual capacity, and total lung capacity, these three cannot be measured by means of spirometry. Next, let us see the methods for measurement of FRC. So how can we measure the functional residual capacity? Because we have known that spirometry can't measure it, so let us see other alternatives. The first one is helium dilution method. So helium dilution method can measure the FRC. So the formula is V1 of C1 minus C2 by C2. So here the V1 is the initial volume and C1 is the initial concentration of helium and C2 is the final concentration of helium. So and second method we can use is nitrogen washout method. Here also we can find out FRC, but the formula here is C1 V1 by C2. So again, the C1 is the initial concentration of nitrogen, C2 is the final concentration of nitrogen, V1 is the initial volume. So like this we can find out by these two formulas, the helium dilution method and the nitrogen washout method, we can use this. Next, coming to the body plethysmography. So it is the most clinical method, most commonly used method. So let us see what it is. The subject, that is the person or the patient is said to sit inside a box and they are forced to and they are said to breathe in and out in the box itself. So it measures the volume changes at the level of lung, so pressure changes at the level of mouth, and it is based on the Boyle's law. So it mainly measures the volume changes at the level of lung and also measures the pressure changes at the level of mouth. So it is mainly based on Boyle's law. You know, in Boyle's law, pressure is inversely proportional to volume. So we have a formula like PMI into VLI is equal to PMF into VLI plus delta V. So here P is the pressure and V is the volume and M is the mouth, L is the lung, I is the initial and F is the final. So you can see here, this is a pressure in the mouth initial into volume in the lung initial is equal to pressure in the mouth final into volume of the lung initial plus delta V. So delta V is the change in the volume and here PMI is the 760 millimeters of mercury and F is the final. So next, let us see the dynamic lung volumes and capacities. So the time dependent procedure, dynamic are time dependent and they are used for diagnosis D for D. So here the subject is asked to take a deep inspiration and fast and forceful expiration for 6 seconds. So first we'll take the deep inspiration and later we'll take the fast and forceful, that is deep expiration for 6 seconds. So it gives a forced vital capacity. So the volume of air expired in 1 second is the forced expiratory volume in the first second, that is called as FEV1. So in a healthy individual, this FEV1 can be like around 70 to 80% of functional forced vital capacity, and diffuse FEV1 is equal to 80%, and if FEV1 by FVC ratio falls, then it may be an indicative of obstructive lung disease, and if FEV1 by FVC ratio remains normal or it may increase, then it may indicate the restrictive lung disease. And next, let us see the flow volume graph. So here you can see in flow volume graph, mainly we are having the effort dependent part. This is actually the upper part represents the expiration and the lower part represents the inspiration. So in the expiration part, this side that is towards the left side, you can see this is a effort dependent part, and towards the right side it is an effort independent part, and this is the PER, that is peak expiratory flow rate. And on the right side you can see the volume of air and the residual volume, whereas on the left side you can measure the total lung capacity. So always remember, from this graph, from the flow volume graph, on the left side you can always measure the TLC, that is total lung capacity. You know total lung capacity is 6, so like that you can remember because it is near to 6, whereas on the right side you can measure the residual volume, so that's why this is the volume of air. So this is about this volume flow graph. So FVC, forced vital capacity, for the graph we can find out by the formula total lung capacity minus residual volume. So total lung capacity, you know, it's 5 minus residual volume is like how much according to graph, let us see and let us do that. So FEV1, that is forced expiratory volume for the first second, is equal to the volume of air which is expired at the first second on the graph. So on the first second of the graph, how much volume is expired, we will find out that. And next, coming to the flow volume curves in lung disorders, especially like COPD, you know, chronic obstructive pulmonary disease. So in this, how the graph looks, let us see. So you can see this dotted line represents the effort independent part is affected, because you know this is effort independent part in the graph, so this is affected. So scooped out, it looks like if you have to take some ice cream scoop, or it also looks like dog leg pattern. And here FEV or FVC ratio falls because this is somewhat abnormal, and it is mainly seen in COPD, that is obstructive lung disease. So in restrictive lung disease, how the graph looks, you can see in restrictive lung disease, you can see the graph is normal but it is restricted, that means it is compressed on all sides. You can see here the dotted line. So the curve is normal in shape but the smaller in size because of compression on all sides, that is restrictive lung disease. So here FEV1 by FVC ratio remains normal or increases. So remember, in restrictive lung disease this ratio may remain normal or increase, but in obstructive lung disease this ratio falls. And next you can see obstructions. So obstruction may be of two types, like it may be variable obstruction or it can be fixed obstruction. In the case of variable obstruction, it is divided into intrathoracic and extrathoracic obstruction. So intrathoracic obstructions are mainly due to foreign body obstructing the airways, and extrathoracic obstruction is like because of sleep apnea. So you can see here three different graphs where you can find out what is affected. So in the first graph you can see expiration is affected whereas inspiration is normal. Whereas you can see the inspiration is affected. You can see the second graph here, inspiration is affected because it should be longer but it is short. The expiration is normal but inspiration is affected. But coming to this third graph, both inspiration and expiration are affected because you can see both sides it has become into the same size. So by this we complete this part. Next we are going to start our alveolar ventilation and pulmonary circulation. So first, main in our lungs, the main part of here is lungs. So lungs, you know, lungs are useful for ventilation. So here you know V tidal, ventilation tidal is like 500 milliliters, we know already. Whereas coming to blood, you know, blood is useful for the perfusion, so it is denoted by letter Q, and it is also called as pulmonary perfusion. So ventilation, the tidal volume 500 milliliter is made up of environmental air and atmosphere, and composition of environmental air, total pressure is equal to atmospheric pressure, that is 760 millimeters of mercury, and nitrogen is 79% and oxygen is 2%, whereas carbon dioxide is nil. This is about, we are talking about the inspired air. So in the inspired air it is like equal to atmospheric pressure with 760 millimeters of mercury. In that, the nitrogen is 79%, whereas oxygen is 2%. Carbon dioxide is completely absent. Next, coming to the partial pressure. So partial pressure is nothing but the pressure which is exerted by the individual gas in the environment. So individual gas has its own pressure, so that pressure is called partial pressure. So here the partial pressure of oxygen is 21% of 760 millimeters of mercury, because oxygen is composing like only 21% of total of atmosphere. So it's like 160, because in 760 21% is 160. And next, coming to environmental air, you know, environmental air is dry with the partial pressure of oxygen is 160, and it decreases made moist longer by spraying of water by the epithelial cells. So actually our lung alveolar epithelial cells spray the water so that they try to make it moist in term of in this process of making the oxygen in the atmospheric air moist. you can see here the inspired air get diluted because it is now adding water. So the partial pressure is reduced due to the addition of water vapor. So water vapor pressure is 47 millimeters of mercury. So the inspired air is 150. So you can see at the beginning in the atmosphere the oxygen is 160 milliliters of mercury, but coming to inspired air means in our lungs, because of hydration of our alveolar vapor pressure, it has converted into 150 milliliters of mercury, means minus 10 millimeters of mercury of pressure is lost. And next, in the inspired air, alveolar partial pressure of oxygen in alveolar air is equal to PaO2, that is alveolar oxygen. So remember, partial pressure of oxygen in alveolar air is denoted by capital A, that is equal to 104. So you can see it is further decreasing to 104 finally. So 160 is in a air, in our environment, 150 is in a inspired air, and 104 coming to the alveoli. So in the alveoli finally the partial pressure of oxygen has dropped down to 104 millimeters of mercury. So PaO2 can be calculated to, that is alveolar gas exchange. So PaO2 is equal to PiO2 minus PaCO2 divided by respiratory exchange ratio. So respiratory exchange ratio. So this is a formula we need to use. This is very important formula. PaO2 is equal to PiO2 minus PaCO2, that is capital A, divided by RER. So RER is the respiratory exchange ratio, that is the volume of carbon dioxide produced divided by the volume of oxygen used. So how much of carbon dioxide is produced divided by the volume of how much of oxygen is used, that gives you 0.8. So PaCO2, here capital A denotes alveolar partial pressure of carbon dioxide, and partial pressure of arterial carbon dioxide can be interchangeably used due to very minor difference. So always remember, PaCO2, capital A and capital small a CO2's partial pressures are interchangeably used. So we have here one more formula. For example, as we discuss this formula, in this formula sometimes in our question we may not find this PiO2. So to find out that PiO2, we have one more formula, that is FiO2 into Pb minus PH2O. So let us see what are those. Here FiO2 is a fractional concentration of oxygen in inspired air. So that is 0.21. It is the inspired air. So for example, if it is inspired air is 100%, then the FiO2 will be 0.1. So here Pb represents the barometric pressure, it's 760 millimeters of mercury, and PH2O represents the water vapor pressure, it's 47 millimeters of mercury. So this is the formula. PaO2 is equal to FiO2 into Pb minus PH2O minus PaCO2 divided by respiratory exchange ratio. So next, let us see a question so that we will understand how to use this formula. So a 62-year-old man with severe respiratory distress is placed on ventilator with FiO2 of 0.5, and his arterial blood gas sample reveals a PO2 of 160 milliliters of mercury and PCO2 of 40 millimeters of mercury. So calculate the alveolar oxygen tension at barometric pressure of 747 millimeters of mercury and respiratory exchange ratio of 0.8. So how to find out this? First, here we need to find out the values. Here alveolar partial pressure of oxygen is given as to find out that formula, we have PiO2 minus PaCO2 divided by RER. So here PiO2, we need to find out the PiO2 here because PiO2 value is directly given. So 0.5 into this formula we are using now, FiO2 formula, because PiO2 we don't know. So PiO2 is equal to FiO2 into Pb minus PH2O. So here FiO2 value is given as 0.5. So 0.5 into Pb is the barometric pressure as given as 747 minus 47 is the PH2O minus 40 divided by 0.8, because PaCO2 is 40, they are given that, you can see here, and RER is 0.8, that also they given. So just by substituting all those values, we finally get PaO2 is equal to 300 millimeters of mercury. So we got that answer. So PaO2 is equal to PiO2 minus PaCO2 by RER. So expired air PO2 is equal to 120 millimeters of mercury, that is 16% of oxygen. So remember that even in expired air we have some oxygen, like about 120 millimeters of mercury, that is like equal to 16% of oxygen. So mouth on mouth respiration can be done in a person where their oxygen has dropped, because even in mouth on mouth expiration we give the expired air to the person, so that expired air also contains 16% of oxygen, which can save the person. Next you can see the minute ventilation. Minute ventilation is equal to tidal volume into respiratory rate. So we know tidal volume is 500 milliliter, respiratory rate on an average is 12 per minute, so we get 6 liter per minute as a minute ventilation. So tidal volume is 500 milliliters. It is further divided into dead space ventilation and alveolar ventilation. Dead space ventilation is there is no gaseous exchange that is present. The air which is present in conducting airways is called in dead space ventilation. It is like about 150 milliliters. Whereas alveolar ventilation, actually the gaseous exchange takes place here in alveoli, so that is like about 350 milliliters. So dead space ventilation is mainly divided into three types. So that is anatomical dead space, alveolar dead space and physiological dead space. The anatomical dead space is in conducting airways and it is 150 milliliters. And in all healthy individuals, always remember anatomical dead space is equal to the physiological dead space. So what is physiological dead space, we'll see. Next, coming to alveolar dead space. Actually alveolar dead space is pathological, always pathological, so it should be completely nil or zero in healthy person, because only in pathological conditions the dead space may be present in alveoli, because alveoli is an exchange site, so only few times there may be dead space there. Physiological dead space is equal to anatomical dead space plus alveolar dead space, so it gives a total dead space. So always remember, in healthy individuals anatomical dead space is equal to physiological dead space, that is alveolar dead space is 0 in case of no pathology in a healthy person. So next here we'll see the measurement of anatomical dead space by single breath nitrogen method. It is also called as Fowler's method. And physiological dead space is measured using Bohr's equation. So Bohr's equation, BD is equal to VT of PaCO2 minus PeCO2 divided by PaCO2. So here VD is a dead space, VT is a tidal volume, PaCO2 is alveolar air of carbon dioxide and PeCO2 is the expired air. So here VD is equal to VT into PaCO2 minus PeCO2 by PaCO2. So this is an important formula in Bohr's equation, which is mainly used to measure the physiological dead space. So if we see a question regarding this, we can get the idea. So you can see all the values are given. The tidal volume is 500, PeCO2 is 30, PaCO2 is 45. Calculate the dead space, and so dead space formula VD is equal to VT into PaCO2 minus PeCO2 by PaCO2. So if we do this, we'll get 167. So VT by BT ratio is normally 30%. Dead space divided by tidal volume ratio is equal to PaCO2 minus PeCO2 by PaCO2. So alveolar ventilation is useful ventilation, because all those dead space are not useful. So alveolar ventilation per minute is 350 milliliters into respiratory rate. So 350 into 12 is equal to 4 liter per minute. So ventilation per minute, alveolar ventilation per minute, can also be calculated by another formula, that is TV minus DS into RR, means tidal volume minus dead space into respiratory rate. Next, let us see blood perfusion. So pulmonary circulation per minute is 5 liter per minute, that is deoxygenated blood. So components are pulmonary artery, it is carrying deoxygenated blood to the lung, and pulmonary capillaries, where oxygenation exchange of gases takes place, and pulmonary veins, the oxygenation of blood, oxygenated blood is going to the heart. So pulmonary circulation is highly distensible and low pressure circulation. So you can see there are mainly three zones in lungs. So here PA represents alveolar pressure, PA represents arterial pressure, PV represents veins pressure. So in the zone 1, at the apex of lung, there is no blood flow, whereas coming to zone 2, there is a pulsatile flow, where it is also called as waterfall effect in the middle zone, whereas zone 3 is continuous and maximum flow. It is also seen in the base of the lung. So next, let us see the unique features of hypoxia in respiratory circulation. Mainly whenever there is hypoxia, means there is low oxygen in respiration system. So systemic circulation normally they lead to vasodilation. The unique feature of pulmonary circulation is they always undergo vasoconstriction. So this mechanism is seen only in lungs, because oxygen specific potassium channels are specific for lungs. So we also have why this is seen, because oxygen specific potassium channels are present in lungs. So because of this potassium, oxygen sensitive potassium channels are activated in hypoxia. See, because of this the potassium channels get accumulated inside the cell, because a potassium channel is closed here. Because of hypoxia, potassium channel is completely closed. If potassium channel is closed, there is no chance for potassium to go out of the cell, so potassium just accumulate inside the cell. When potassium accumulates, positive charge is accumulating, means the resting membrane potential is now moving towards the threshold. So because of this, the calcium channels are also activated and it leads to vasoconstriction. So next we have a question. A patient with a dead space of 150 milliliters, FRC of 3 liters, tidal volume of 650, ERV of 1.5, TLC of 8 liters, and respiratory rate of 15 breaths per minute. What is the alveolar ventilation? So we know what is the alveolar ventilation formula. So alveolar ventilation is equal to TV minus DS, dead space, into respiratory RR. So DS into RR. So here TV, tidal volume is 650. So 650 minus dead space, I think they have given dead space for us of 150 milliliters, 150 into RR. What is the respiratory rate they given? 15 breaths. So if we solve this, so 650 minus 150, we know it's 500. So 500 into 15. So you can say I calculated it for easy. So you can see 7,500. If we this is in milliliters, right? We need to convert into liters. So convert into liter, we get 7.5 liters. So like this, we need to calculate the sums if we get the sums in our questions. This is ventilation perfusion ratio, or continue our respiratory physiology series. So actually the normal ventilation by perfusion ratio is called as V by Q ratio or V by Q matching definition. So ventilation by perfusion is equal to alveolar ventilation divided by pulmonary circulation. So normally our alveolar ventilation, in our previous video we talked it is 4 liter per minute, and pulmonary circulation it's 5 liter per minute. So if we divide both of them, we get 0.8. So normal ventilation perfusion ratio is 0.8. Actually this 0.8 saying, we have seen 3 zones of the lung, the apex, middle and the basal zone. So in the middle zone of the lung, we can find this perfect ratio of V by Q is equal to 0.8. So normally the V by Q ratio in the apex of the lung is highest, it has 3.2, and that is the reason why, because of this higher perfusion and higher ventilation, the Mycobacterium tuberculosis can flourish there in this region because of higher supply of even ventilation perfusion. So middle of the lung have V by Q ratio of exact 0.8, whereas the base of the lung have lowest value of 0.6. Next come to ventilation perfusion mismatch. So for example, if Q, that is if perfusion is 0, then V by ventilation by anything by 0 gives you infinity value. So there is no perfusion, so means low blood supply, means you can understand here the ventilation is wasted. So ventilation is wasted, only airflow is present in absence of blood flow. So only airflow is present in absence of blood flow. So there is no gas exchange because only air is coming. Ventilation is wasted. Blood flow is going on, but you can see here perfusion is 0. There is no blood flow, no perfusion. Only air is coming. So there is no gas exchange because the gas is now just in a conducting pathways, means just in a dead space. So V by Q infinity is mainly seen physiologically in anatomical dead space because just it's in a conducting pathway, but pathologically it is seen in pulmonary embolism. You can understand whenever there is an emboli, it occludes the vessel. Because of this, there is blood flow, there is no blood flow in that area. So because there is no blood flow, only ventilation will be coming and no gaseous exchange. Whereas sometimes V may be 0. So when V is 0 also, there is the value will be infinity. There is no ventilation or airflow. Now the ventilation is not there, but the blood is flowing. So if there is no ventilation, the blood flow which is going, it is waste. There is also no gas exchange. So here the perfusion is wasted and only blood flow is present in the absence of airflow. So there is no gas exchange here. So here also V by Q is 0. Here the V by Q is 0, and it is seen mainly physiologically in shunt blood, 2% of cardiac output. Shunt blood, why we call it shunt blood? Because here there is no gas exchange. Directly the blood which is coming from a pulmonary side, it is going into systemic side. And pathologically, there is foreign body obstruction of airways, that is obstruction airways collapse. So foreign body obstruction, pathologically any foreign body has come and obstructed us. So because of that also, you can understand there is no airway coming, but blood is flowing. So this may lead to collapse of airways. And next let us see the ventilation perfusion diagram is also called as oxygen carbon dioxide diagram. So if V by Q is 0, here you can see the V by Q is 0, there is no gas exchange, the blood is shunting because already here the ventilation is coming, but the perfusion here ventilation is 0, but the perfusion is going, so perfusion is wasted here. So you can understand that is the reason why here the carbon dioxide is very high when compared with oxygen, because the ventilation is not there. Means the blood which is coming from the venous side, it has more carbon dioxide, that only continues. Here the blood is not oxygenated, so oxygen remains 40. So this is also called as shunt blood in this point. Or any foreign body obstruction of airways also maybe takes place. And coming to V by Q ratio normal. In normal, it's perfectly 0.8 in the middle part of the lung. Here the proper gas exchange as takes place. So because of this, the PO2 is 104, whereas PCO2 is 40. So that is as oxygenation as takes place, 104 is the oxygen level. And coming to V by Q ratio at infinity, there is no gas exchange, because at infinity actually the perfusion is 0, means air is coming, ventilation is wasted here. So anatomical dead space, because ventilation is wasted, and pulmonary embolisms are the reasons. So here the oxygen level is 149, or you can say 150. We already know in inspired air the oxygen is 150, whereas carbon dioxide is 0. And here also in alveolar air our carbon oxygen is 104. But here you can see our inspired air has 150 of carbon dioxide, oxygen. But here carbon dioxide is completely 0, because in this case we know here the perfusion is 0. So as the perfusion is 0, no carbon dioxide is coming here. So carbon dioxide is 0, whereas oxygen is 150 in an inspired air. So this is all about our ventilation perfusion ratio. Let us continue our physiology revision series. So we are in environmental physiology. So the physiological conditions here, mainly environmental physiology means in altered environments how our physiology, how our body adapt to it, let us see. So like in high altitude or in deep sea or in space, so how our body reacts, let us see. So mainly in high altitude the atmospheric pressure is 760 milliliters of mercury, and the composition of air is 21% only as in our normal air, but the partial pressure decreases. Partial pressure is 760, but here in higher levels it's 160. Whereas at high altitude you can see the barometric pressure decreases, whereas the composition is same, and the partial pressure of oxygen decreases, mainly there's hypoxia. So now let us see what are the compensatory changes. So compensatory changes are like in response to long standing hypoxia, like if the people are staying there for a long time, then how they compensate, how they adapt there, that is called as acclimatization. So what are those acclimatization, what happens there, let us see. First one, if you stay long time for this low atmosphere hypoxia in that high altitude, first there is increase in pulmonary ventilation, because now you need to ventilate more. So earliest response is this. So hypoxia mainly stimulate the chemoreceptor. This in turn gives the chemoreflex, which leads to hyperventilation. Whereas the hyperventilation leads to respiratory alkalosis, because in hyperventilation lot of carbon dioxide is lost. As the carbon dioxide is lost, it is called alkalosis, respiratory alkalosis. So because of this there may be chance of hypocalcemic tetany. So to prevent this hypocalcemic tetany, normally the kidney tries to compensate it by bicarbonate excretion. So by removing bicarbonate from your body, you can understand now that alkalosis may be lost, and again the body may come to normal. So next there is erythropoietin, increase in production of erythropoietin from our kidney, so that we can increase RBC. Why to increase RBC? Because now we need to increase the oxygen carrying capacity, right? And third one is VEGF, that is endothelial growth factors. These are many angiogenic, they produce more vessels, so that there is higher chance of blood supply. And in increase in diffusion of gases and diffusion capacity, of course they should increase now, because there is low oxygen supply now, so we need to increase them. And fifth one is cellular acclimatization. Even in the cell there are some adaptations, like increase in activity of mitochondrial enzymes. So mitochondria should work more now, so that increase in oxygen utilization to produce more energy and more essential proteins, so all the ATP which are required for to sustain in this high altitudes. So if a person is not able to adapt to this altitude, then he may get sickness. that sickness is of two types, like acute mountain sickness, or it can also be chronic mountain sickness. So first let us see what is the acute mountain sickness. So this occurs within 6 to 12 hours of ascent to high altitude. Just within 6 to 12 hours only, if the person observes this, all this clinical features like non-specific symptoms, nausea, vomiting, confusion, then we should immediately, the treatment is nothing but to bring him down from that mountain, that is descend to the lower altitude. And extreme form of acute mountain sickness will be like some edema in lungs and also edema in brain. So it's like HAPE means here high altitude pulmonary edema, and also you can see high altitude cerebral edema. So immediately we need to descend the person to the lower side altitude, and oxygen supplementation should be given, and even if possible calcium channel blocker like nifedipine and dexamethasone is a steroid. So this we can give this to treat the patient. And coming to chronic mountain sickness is also called Monk's disease. So actually here what happens is there are excess erythrocytosis, means as this person has been for long time, they have more amount of erythrocytes. So whenever they have more erythrocytes, the pulmonary hypertension begins, and also you can see the core pulmonary, whenever pulmonary hypertension, heart feels it hard to pump, so this leads to core pulmonary. And the treatment here we can give is venesection and acetazolamide. So you should remember the treatments for acute mountain sickness just to bring the person down. In extreme form of acute mountain sickness, we need to give oxygen supplementation, calcium channel blockers like nifedipine, dexamethasone. Whereas in chronic mountain sickness, we should give venesection and acetazolamide. So these are the treatments, these are the clinical features if we stay longer time in mountains or high altitudes. Next, coming to deep sea physiology. So okay, we have completed mountain, now we will go into the deep sea, what happens there. So actually why the people go mainly to employment, so that employment people are called casein workers, and some for military operations or for just enjoyment recreation people go there. So deep sea actually have high barometric pressure. So this you can compare analogy with echoic den is also decompressed, you can see with high pressures. So if you open the bubbles come out, right? So even at the sea level, the atmospheric pressure 760 millimeters of mercury is equal to 1 atmospheric pressure, and at 10 meters it's like 2 atmospheric pressure. If you go more deeper, like at 20 meters, you can see it's 3 atmospheric, means very high pressure. So in that very high pressures, if you open the Coke bottle, suddenly the bubbles come very fast, but if you open it slowly, you can understand the bubbles come slow. So what happens here, let us see decompression sickness or Casein's disease. As the people working there called caseins, so the disease name is also Casein's disease. So this disease is also called as dysbarism. So here actually in high barometric pressure, the gases are compressed a lot. So if ascend rapidly, the decompressed gas nitrogen comes out as bubbles, same like our Coke tin, right? So clinical features here are, if the person comes out suddenly from deep sea, then the nitrogen can, mainly the nitrogen bubbles are formed, which have a capacity to, cross the blood-brain barrier. So if they cross the blood-brain barrier, this may lead to nitrogen narcosis, that is nothing but euphoric stage. So the bubbles also may accumulate in joints, causing pain, then it is called bends. And the bubbles may also go into the lung and lead to shortness of breath, that is called as chokes. And even air embolism is an important cause of death. So all this may take place if a person is coming directly from the deep sea into the normal atmospheric level. So instead of that, we give treatment as hyperbaric chamber. So actually what the treatment is, here we say that person to go into this chamber, and what this chamber does is it slowly brings the person to the normal value, so that as you open the Coke, slowly the bubbles will not come that much, right? So in the same way here also, so slow decompression of gases, so it may prevent this disease, Casein's disease or decompressed sickness. Now let us go into space. So it's like a tourism now. We have went to mountains, we have went to deep sea, now we are going to space. So what happens in space? Actually, different gravitational forces, which are nothing but also called as G forces in short form. So we have like this 3 G forces: positive G, negative G, and zero gravity or microgravity, micro G. So these are 3 types of gravitational forces. If you go into space, so these are going to attack you. So what are those? First we'll see what is this positive G. So this is a huge gravitational force which is acting from head to foot. Actually it's like normal. Positive G means even on us now the gravitation acts on head to foot, right? So actually because of this there is venous pooling of blood. and there is decreased cardiac output, and also there is decreased brain blood flow. Of course, if cardiac output drops, even the blood flow to the brain, not only brain, all organs decrease. So especially brain is important, right? So as the blood flow is decreased to brain, it may lead to unconsciousness or even blackout, you can see. So it is blackout. Whereas coming to negative G, it is huge gravitational force which is acting from the downward, from foot to the head. So this is positive, so in this the right direction from head to foot, whereas this is negative, so in opposite direction from foot to head. So here actually the venous return increases. You can understand this from foot to head means as it is coming upward, of course from inferior vena cava more blood flow, so more venous return. Of course, if more venous return, more cardiac output. If more cardiac output, then it leads to increase in blood flow, in cerebral blood flow, especially in eye and brain vessels. They are congested, so that you can see as red out. So here blackout, here red out. So it's interesting. Now let us see what happens in zero gravity. What kind of out we'll see here. Let us see. So this is called as microgravity. Here there is loss of calcium and phosphates. So if they are lost, what happens? Bone is made up of calcium phosphates, right? So if calcium phosphates are lost, there is loss of bone mass. And actually this is actual in space. In space we say zero gravity, microgravity. So in space these are the conditions which takes place. So even the space travelers should take all these measurements. So there would also be loss of muscle mass and reduced number of RBC, and also decrease in work capacity. So all these are seen in a zero gravity. So these are all about our environmental physiology which we have completed. Diffusion and transport of gases. So mainly in alveoli, the inspired air has high oxygen and low carbon dioxide. So the air which we inspire mainly have high amount of oxygen, it has only low amount of carbon dioxide. Whereas in lungs, you can see the deoxygenated blood mainly contains the lungs will have deoxygenated blood because it need to oxygenate now. So the deoxygenated blood in the lungs mainly contain, of course, low oxygen and high amount of carbon dioxide. So now you can understand, as in lungs there is high amount of carbon dioxide, and in atmosphere there is now low amount of carbon dioxide. So the diffusion takes place from the lungs. The high carbon dioxide goes outward into the air, whereas in inspired air you can see we are having high amount of oxygen and low carbon dioxide. So because of this, inside now we are having low oxygen. So now the inspired air, that high oxygen will be coming to us inside. So diffusion happens from the high concentration to low concentration. And the deoxygenated blood stays inside the vessels for like 0.8 seconds. So as we said, the deoxygenated blood in the lungs, so it will stay in that vessels for 0.8 seconds. Let us see the diffusion of gases. So normally the diffusion of gases passive transport process, that is they don't require any ATP or energy. So this is a simple diffusion process, and we have fixed law which says that diffusion is always directly proportional to concentration gradient, and also it is directly proportional to area, but it's inversely proportional to thickness, because if the diffusion membrane is very thick means the diffusion decreases. If the diffusion membrane is lesser thicker, when increased diffusion. So these are like inversely proportional, but all this concentration gradient, area, solubility, especially the lipid solubility, these all are directly proportional. And even the size of the particle is inversely proportional, because if the size of the molecule is high, then diffusion will be low, and if the size of the particle is low, then diffusion will be high. Now let us see the respiratory membrane. The respiratory membrane, it's actually present in between the alveoli and the blood vessel. So its thickness and area are required for the diffusion. Mainly depends on thickness and area. And next, coming to clinical correlation. In emphysema, actually the trypsin is an protein which is overactive. So because of this, the protease mediated destruction of membrane surface area means this respiratory membrane is destroyed in the case of emphysema. Respiratory membrane. The membrane surface area is destructed because of trypsin overactivity. So because of this, there is decreased diffusion, decrease in area. And in pulmonary fibrosis, you will see there is decrease in diffusion and increase in thickness. Actually, fibrosis, in the name you can understand, the membrane is thickened. So as there is the high thickness, they both are inversely proportional, so diffusion is decreased. Next, coming to diffusion measurement. So how we can measure diffusion? We use one test that is called as DLCO. DLCO means diffusion capacity of lung for carbon monoxide. CO means carbon monoxide. So diffusion capacity of lung for carbon monoxide. So by using carbon monoxide we try to measurement the diffusion. So why we used carbon monoxide is carbon monoxide has 210 times more affinity for hemoglobin when compared with either oxygen and carbon dioxide. So the normal DLCO value, the normal value is 25 milliliter per minute per millimeters of mercury. So whenever there is this is like emphysema, pulmonary fibrosis, anemia, we will see there is decrease in DLCO, means decrease in affinity for hemoglobin. Why? Because in emphysema the membrane is disturbed. In fibrosis also the diffusion is decreased, and even in anemia, anemia, hemoglobin is very low. As hemoglobin is very low, then with what the carbon monoxide can bind. So in all these conditions like EPF, emphysema, pulmonary fibrosis, EPA, or you can remember PAE. So in this all three conditions DLCO is decreased, whereas you can see the DLCO is increased especially in pathological conditions like polycythemia, because in polycythemia there is increase in RBC. If it is increase in RBC, of course increase in hemoglobin. So in polycythemia the DLCO increases, whereas this is pathological, but in physiological conditions normally if you do exercise you will have higher amount of DLCO, means higher affinity, higher binding of hemoglobin with gases. So actually when you compare carbon dioxide with oxygen, carbon dioxide is 20 times more soluble when compared with oxygen. Now let us see next the transport of gases. So first we'll see our major oxygen transport. So oxygen is, of course, the major transport is done with hemoglobin. It binds with hemoglobin. So 99% of the oxygen is mainly transported by means of only hemoglobin. Whereas carbon dioxide transport, everyone thinks only oxygen will bind with hemoglobin. Even carbon dioxide can bind with hemoglobin and transport it, but only 30%. So it is a minor transport. So for hemoglobin, the major transport is oxygen and the minor transport is carbon dioxide. So that major, then even carbon dioxide should have one major transport, right? So that major transport is bicarbonate. You can see 70% of the bicarbonate is transported by means of 70% of carbon dioxide is transported by means of bicarbonate. Next let us see oxygen transport. So oxygen transport measure the 1 gram of hemoglobin transports 1.34 milliliter of oxygen, and 15 grams, 15 grams it's a normal value, right? So for 15 grams of hemoglobin it transports like 20.1 milliliter of oxygen per 100 ml. So 1 gram transports 1.34, whereas 15 grams transport 20.1 ml of oxygen per 100 ml. And the minor transport of is done in dissolved form of oxygen, that is PO2, partial pressure of oxygen. So the partial pressure of oxygen is 0.3 milliliter of oxygen per 100 ml. So it determines the partial pressure of oxygen. So remember, in dissolved form it's 0.3, whereas in major form like it's 1.34. For 15 grams it's 20.1 milliliter of oxygen per 100 ml. Next we'll see the oxygen dissociation curve. In short form it is called as ODC. So actually the shape of oxygen dissociation curve is sigmoid, and the partial pressure of oxygen is 100. When the partial pressure of oxygen is 100 millimeters, then the curve is at plateau, then no more hemoglobin is available. So in the graph, if you see at the partial pressure of oxygen at 100 millimeters of mercury, actually you will get a plateau where there is no more hemoglobin available. So oxygen hemoglobin curve 50% saturation is called as P50. At P50 the values of partial pressure of oxygen is 27 millimeters of mercury, and different factors can shift this curve to left or right. So we'll see what are all the factors. Actually the one molecule of hemoglobin can carry 4 molecules of oxygen, or you can say 8 atoms of oxygen. So now let us see oxygen molecules and hemoglobin molecules, how they bind. So mainly oxygen binds to first T hemoglobin. T hemoglobin means tight hemoglobin. First it's bind with tight hemoglobin. As the name you can see, tight means it's difficult for breathing. Next actually this tight hemoglobin have some, because of this binding there are some breakage of salt bridges. So because of the breakage of salt bridges, now these 3 hemoglobins can directly happily bind to R hemoglobin. R hemoglobin means relaxed hemoglobin, so they can easily bind, but only first one is tight. So now let us see the theory of cooperativity. This is called theory of cooperative, where you can see because of tight binding first, these 3 are relaxed. So that is the theory of cooperativity. First oxygen molecule bind with difficulty and remaining binds with ease. And this is the main reason for the sigmoid shape of a oxygen dissociation curve, so that you need to remember. And next we have left and right shift of the curve. So why actually it happens, let us see. So if oxygen binds with hemoglobin, or if there is loading of oxygen in lungs due to high affinity, then it is causing left shift of oxygen dissociation curve. And if hemoglobin is released, or it is unloading of oxygen to the tissues, you can see hemoglobin is unloading oxygen to the tissues due to low affinity, then right shift takes place of ODC. So we have two effects like Haldane effect and Bohr's effect. Actually, Haldane effect is loading of oxygen in lungs lead to unloading of carbon dioxide. So Haldane effect is loading of oxygen in lungs, means this process, not this process, loading of oxygen in lungs leading to unloading at the same time as the oxygen is coming into the lungs. Now the carbon dioxide is unloading outward, whereas Bohr's effect, that is release of oxygen at the level of tissues. As you can see, the oxygen is released at the level of tissues. Now the carbon dioxide will increase here, so that is Bohr's effect. So you can remember only this, release of oxygen at the level of tissues. Haldane effect, loading of oxygen in the lungs leading to unloading of carbon dioxide. So this oxygen to hemoglobin, here you can expect the Haldane effect, whereas hemoglobin to oxygen, here you can expect the Bohr effect. Now let us see the causes of right shift. Actually, we have what are the causes of right shift and left shift. Actually, in the graph, for example, this is a normal curve. Then this upward one will always represent the left shift, and the downward one will always represent the right shift. Only if that you remember, it's enough. So what are the causes? Now we need to see what are the causes of right shift. As I said, right shift means downward. So what are the right shift of ODC causes? Are like whenever there is hypoxia, that is whenever the partial pressure of oxygen is low. Hypercarbia, that is whenever as oxygen is decreased, the carbon dioxide increase, that is called hypercarbia. And when a carbon dioxide is increased, even hydrogen ions increase, so that lead to decrease in pH, that is acidosis, and increase in 2,3-diphosphoglycerate or 2,3-DPG, which is an intermediate product in anaerobic glycosis. So whenever the anaerobic glycosis takes place, then 2,3-DPG increases. So this, and high altitude prolonged hypoxia, in this case also there is right shift, and in exercise physiological. So all the 6 causes are the causes for right shift of ODC. So in chronic acidosis, actually remember one important point, in chronic acidosis inhibit the glycolytic enzyme, so 2,3-DPG have no effect on the curve. So this is very important in chronic acidosis. In normal acidosis, normal 2,3-DPG, we have normally right shift only, but in the case of chronic acidosis, glycolytic enzyme is inhibited. We already said only in aerobic glycolysis 2,3-DPG will increase, but here as the glycolytic enzyme decrease, 2,3-DPG also increases, so there is no effect on the curve. Now let us see what are the causes of left shift. Left shift means the curve is higher. So left shift of ODC, left shift causes are hypocarbia. So they will be all reverse of right shift, like hypocarbia, decrease carbon dioxide. Because of this, alkalosis, decrease hydrogen, so increase in pH. And HbF, that is hemoglobin of fetus, has high affinity to oxygen and has less affinity to 2,3-DPG. And also stored blood inhibit the glycolysis in 2,3-DPG. And next, carbon monoxide. So these are all the 5 reasons for the left shift of ODC. Now let us see the carbon dioxide transport. So as we understood oxygen transport, how carbon dioxide will transport? The major transport already discussed, bicarbonate 70%, and the minor transport from hemoglobin, carbon dioxide combines with hemoglobin 30%. So actually, this is RBC and this is our capillary around it. So actually carbon dioxide, on entering into the RBC, it binds with water to form carbonic acid H2CO3, and this carbonic acid it break down into H plus and bicarbonate. This bicarbonate again comes back into this vessels to transport, whereas as the positive has come inside, so the negative chlorine will go. This is called as chloride shift. So as the chlorine is going inside, this binds this H plus, it should not be inside because it may again lead to acidosis, so it is buffered by hemoglobin, and this chlorine will bind with some other molecule. So what is Hamburger phenomenon? For every bicarbonate ion efflux, there is chlorine influx to maintain electronegativity. electron neutrality. So the packed cell volume PCV is 3% higher in venous blood. Why it is higher? Because as the chlorine is coming inside, always water follows, either sodium, chlorine. So water also follows it. So packed cell volume is increased in venous blood due to chlorine influx, which is osmotically active, drags water into the cell. So causes the cells to swell, and the H plus ions formed are buffered by hemoglobin. Next, let us see, even as oxygen have dissociation curve, even carbon dioxide have. So in venous blood, the pCO2 normal values are 45, that is 52 ml of carbon dioxide per dl is present. In arterial blood, pCO2 is 40, right? So 48 ml is present. So the difference between two, it will give you 5 or normally 4 ml of carbon dioxide is transported. So that gives us the oxygen dissociation normal curve. So that 4 ml of carbon dioxide which is transported. The difference between 52 minus 48. 52 is in venous blood, 48 is in arterial blood. So that's it. We completed overview of our diffusion of transport of gases. We're going to start the neural regulation of respiration. So mainly the regulation of respiration is not only by neural, it is divided into two parts like chemical regulation and neural regulation. Neural regulation, of course, it involves the brain, especially the pons and medulla in the brain. Whereas coming to the chemical regulation, here the chemoreceptors play a major role, which are sensitive to change in oxygen, carbon dioxide and hydrogen. But this neural regulation receptors are also called as central chemoreceptors, which are mainly sensitive for change in carbon dioxide. We'll see all those in details. So neural centers of respiration are pons. So pons mainly contain two major groups of neurons. One is the pneumotaxic center, which is present in an upper part. According to diagram, you can see in pons there are two types of neurons. The upper one, two major groups of neurons. The first one is a pneumotaxic center and the below one is a apneustic center. So the medulla also have three groups of neurons, that is the dorsal respiratory group, ventral respiratory group, and also we have pre-Botzinger complex, which is also called as the pacemaker neuron for respiration. So let us see what are the three types which are present in medulla. So in medulla you can see this is called as pre-Botzinger complex. P for P, it is a pre-Botzinger complex which is a pacemaker of respiration, and this ventral respiratory group, and this is a dorsal respiratory group. Now let us see each of this function. So the neural regulation, first let us start with pons. In upper pons, as we saw, there is pneumotaxic center. So this mainly limits the inspiration by inhibiting apneustic central. So this pneumotaxic center, this one which is present in upper side of a pons, it has mainly inhibitory effect on inspiration by inhibiting the apneustic center. So by this only you can understand apneustic center promotes the inspiration. That's why the pneumotaxic center want to limit the inspiration. So it is inhibiting the apneustic center. So let us see. And one more thing, it limits the inspiration by inhibiting apneustic center and increases the respiratory rate. So you can understand when the inspiration is decreased means the number of respiratory rates are increased. Next, coming to lower pons we have the apneustic center which prolongs the inspiration. So for prolonging inspiration we need apneustic center. So now in medulla we have the pre-Potzinger complex, which is mainly useful for the initiation of respiration. It is a pacemaker. And the dorsal respiratory group, you can see here, these are the dorsal respiratory group which mainly generate a ramp signal which results in steady rise in tidal volume. So ramp signal is nothing but the tidal volume is increasing in steady state, not directly. So that is called ramp signal, which is initiated by a dorsal respiratory group. And we also have the ventral respiratory group, you can see here. So this is in short form called VRG. They has no role in controlling expiration at rest. So it is a passive process. In a passive process, normally lung is like a spring, so it will just come back passively. But VRG, this is mainly useful in the case of forceful expiration during exercise. Especially in exercise, the expiration also is not passive. We need to forcefully do it. So in the case of forceful expiration, mainly this ventral respiratory group is useful. So pre-Botzinger complex is used for the initiation of respiration. Dorsal respiratory group to provide the ramp signal which results in steady rise in tidal volume, and ventral respiratory group is used for controlling the mainly expiration, that is forceful expiration. So the extra respiratory effort during exercise is called extra respiratory drive or overdrive phenomena. So this ventral respiratory group which is giving this forceful expiration drive, that is called as extra respiratory drive or also called as overdrive phenomena. Next, let us see integration of respiration. So how we integrate it? So mainly we have inspiration. Inspiration is initiation of inspiration pacemaker, that is pre-Botzinger complex in the medulla. And next it gives an impulse to the spinal cord by means of phrenic nerve, that is C3, C4, C5. And next this gives impulse or stimulus to the diaphragm to contract, and as the diaphragm contracts, this leads to inspiration. So this is how the inspiration pathway follows. And next, coming to maintenance. So this is integration. So how we maintain the inspiration? So mainly apneustic center, you can see the apneustic center which is present mainly in the pons lower part. So this apneustic center lower pons is mainly used for stimulation of dorsal respiratory group, which is also called as DRG. This dorsal respiratory group gives a ramp signal, and this in turn leads to smooth rise in tidal volume to 500 milliliters. And next, let us see termination of respiration. So till now we have seen how respiration is formed, how it is maintained. So respiration is mainly formed by initiation of respiratory center, that is a pre-Botzinger complex, and it is maintained by apneustic center, and whereas termination is by pneumotaxic center. So pneumotaxic center and also vagus efferents from the lung, they all they try to inhibit the apneustic center, so that they are indirectly inhibiting the dorsal respiratory group of neurons. So expiration is a passive process at rest. No neuron control is required, but forceful expiration during exercise is controlled by VRG, we already discussed. So the initiation of respiration function of medulla, and the regulation of respiration is a function of pons. So now let us see different kinds of lesion and how they are going to affect this regulation. So mainly the neural centers, if the lesions are below the medulla, then the respiration stops, leading to death. If the lesions are below medulla, because from medulla they should go into spinal cord, so if the lesions are below, then they may not go into the spinal cord, so finally the respiration stop, leading to death of the person. And if pre-Botzinger complex can't activate spinal cord, no initiation of inspiration. And next, if the pre-Botzinger complex is absent, the respiration becomes voluntary process. This can lead to death in sleep. If the respiratory is involuntary, we always need to think about it. So even in sleep, normally in our sleep our pre-Botzinger complex take care of respiration, but here in this kind of person, if pre-Botzinger complex is absent, then in sleep they may die because they will not think about respiration in sleep. So this is called as Ondine's curse. So the treatment for this is mechanical ventilation. So in these people, even in sleep they can respire only if we give mechanical artificial ventilation. So if the lesions are at pontomedullary junction, the pons regularize respiration, medulla initiates respiration. So lesions in pontomedullary junction leads to irregular respiration, because normally pons will regular respiration, medulla initiate. So if it is the lesion is in pontomedullary junction, then it may lead to irregular respiration. Next, coming to lesions in mid pons with vagus cutout. If vagus is cut out and also there is a lesion in mid pons, then normally the upper pons is a pneumotaxic center and lower pons is apneustic center. So when apneustic center is not inhibited out but activated, so here the apneustic center is activated, so because of this there is prolonged inspiration, so that is leading to apneosis. And next we have the pulmonary reflexes. So mainly we have three types of pulmonary reflexes. One is Herring-Brewer reflex, head paradoxial reflex, and J reflex. So Herring-Brewer reflex is a protective reflex. Actually, this reflex is conveyed by slow adapting myelinated vagal fibers. So what is there in Herring-Brewer reflex? Inflation reflex. So in case of prolonged inspiration, the inspiration is inhibited, duration of inspiration decreases, duration of expiration increases in the case of Herring-Brewer inflation reflex. So this also have deflection reflex in the case of prolonged expiration. So here actually what happens, expiration is inhibited, duration of expiration decreases, duration of inspiration increases, so it prevents the lung collapse. So vice versa, if there is problem with inspiration, then it will be inhibited. If there is problem with expiration, it will be inhibited. Next, coming to head's paradoxical reflex. So this is actually opposite to the Herring-Brewer reflex. In case of prolonged inspiration, it increases a further inspiration. So this is like a positive feedback. So this occurs only once in lifetime. It occurs especially in newborn with the first breath to replace all the fluid in the lungs with the air. Actually, the prolonged inspiration takes place because in the newborn baby we need to completely replace the fluid with the air. So in that case, it is useful, and every time in every life of a person it happens. That is head's paradoxical reflex. Next, coming to the J reflex. J reflex is seen in patients with breathlessness in case of pulmonary edema especially. So actually these receptors are located in the juxtaposition to pulmonary capillaries, that is nearer to the pulmonary capillaries. These are called as J receptors. And in pulmonary edema, the fluid extravasates from the pulmonary capillary and it tries to stimulate these J receptors. And activation of J receptors mainly result in apnea, immediate or breathlessness, or also in hypotension. So these are all these three cases we'll see activation of J receptors, and also in bradycardia. So not three. In these four cases we mainly see the J reflex. And J receptors were discovered by an Indian physiologist, that is A.S. Paintal, who is AIMS physiologist. So the reflex is mainly mediated through unmyelinated C vagal fibers. So actually this can be traveled by means of unmyelinated, not myelinated. Whereas before you can see here Herring-Draw reflex is by myelinated vagal fibers, but here in the case of J reflex it is by unmyelinated C type of vagal fibers. Next, coming to the altered breathing patterns. So they are also known as like periodic breathing. This altered breathing is called as periodic breathing. So first one, here comes the Cheyne-Stokes breathing. Actually here what happens is due to gradual hypernypia, you can see the graph here. Actually they have gradual hypernypia and gradual hyponypia. Means they are having suddenly high hyperventilation and suddenly low hypoventilation. So whenever there is hyperventilation, we wash out the carbon dioxide, more carbon dioxide. So here the carbon dioxide will go out, means leading to hypocapnia inside or hypocarbia. So again gradual hypocarbia and again suddenly leading to apnea. Apnea means completely absence of breathing here. So here the carbon dioxide again start building. So suddenly carbon dioxide will go out and suddenly it will start build up. That is called as Cheyne-Stokes breathing. So what may be the causes? Normally it is seen, it's normal physiological in the case of sleeping in especially children and adults, but it is pathological in congestive cardiac failure and also in uremia. Next, coming to Biot's breathing, also called as ataxic breathing pattern. So it is a type of irregular respiration. So you can see it's a irregular respiration. Here you can see hypernypia and also apnea. So what are the causes? Damage to medulla or any meningitis. So we need to remember the causes for this. And next, coming to Kussmaul's respiration or air hunger. Actually here it is seen in patients of diabetic ketoacidosis and it is a form of hyperventilation. You can see only hyperventilation is seen here. It is leading to increase in rate and both depth of respiration. Next we have the prolonged inspiratory spasm or apneosis. So this is mainly seen in damage in mid-pons but with vagus cut. We already discussed about this in mid-pons. If the vagus is also cut, what happens? It leads to apneosis. This point as we already discussed, apneosis. So the same, if you see in the case of diagram, you can see it has first hyperventilation, later coming to apneosis, and again having hypoventilation, again apneosis. So like that the graph continues. So this is prolonged inspiratory spasm or apneosis. So we have mainly three types of periodic breathing or abnormal patterns, that is Cheyne-Stokes breathing, Biot's breathing, Kussmaul's respiration, and prolonged inspiratory spasm or apneosis. So by this we complete neural regulation of respiration. Next, now we will start the chemical regulation of respiration. So not only neural, we also have chemical regulation of respiration. So here we have mainly oxygen, carbon dioxide, hydrogen ion changes. So these stimulate these chemoreceptors. So these chemoreceptors may be present even in brain and neck, but now the chemical regulation is mainly related to the neck area receptors. The brain receptors we already discussed, which are nothing but called as central chemoreceptors, mainly located in medulla, especially ventral surfaces, which is surrounding the floor of fourth ventricle. Whereas in the neck we have the peripheral chemoreceptors like carotid body and aortic body. So now let us see what are the central chemoreceptors. Once again, already we completed, but central chemoreceptors are like which detect the carbon dioxide changes, especially hypercarbia, normal respiratory regulation, that is carbon dioxide dependent. So whenever this carbon dioxide changes, then the central receptors get activated. So you can see from actually before we had discussed the neural regulation is also like related to central chemoreceptors. So you can see this central chemoreceptors are like, you can see this is blood-brain barrier, and this is a blood vessel, and this side you can see this is a brain part. So you can see in a blood vessel, mainly whenever the carbon dioxide is increased, or always hydrogen ion also increase along with it. So because of that, this carbon dioxide, hydrogen ion can't cross the blood-brain barrier because it's a charged particle, whereas carbon dioxide is a gas which can easily diffuse, so it can diffuse the blood-brain barrier. So inside coming into the brain, what happens? Carbon dioxide bind with water to form carbonic acid. This carbonic acid, that is H2CO3, in turn break down into H plus and bicarbonate. So this H plus stimulates the central chemoreceptors which are surrounded by the cerebral spinal fluid. So you can see the H plus is the one which can directly activate the central chemoreceptor, but this H plus, you can remember, this H plus is not directly coming from a blood vessel, but it is coming due to the product of carbon dioxide and water reaction. So increase in carbon dioxide and H plus ion only, carbon dioxide can cross blood-brain barrier. Carbon dioxide reacts with water in the presence of carbonic anhydrous to lead formation of carbonic acid. This in turn splits into H plus ion and bicarbonate, and this H plus ion stimulates central chemoreceptors, which in turn directly stimulate by H plus ions in the central cerebrospinal fluid, which is sensitive to high amount of carbon dioxide levels in the blood. So next we have even the peripheral chemoreceptors, which mainly their stimulus is like hypoxia. Whenever there is low oxygen, they get activated. So oxygen sensors are present in carotid and aortic bodies. Especially you have the glomus cells, which can sense this oxygen whenever it is low, especially in hypoxia. So first we'll see normal and next pathology. So normally oxygen sensitive potassium channels are always open whenever there is higher oxygen, so that a lot of potassium goes out. But whenever there is hypoxia, it inhibits this potassium channel. So this potassium channel closes, means you can understand the potassium is starting accumulating inside the cell. As the potassium is accumulating, positive cells lead to moving the cell towards a threshold, so that they go undergo depolarization. So because of this depolarization, the calcium start opening, and calcium channels calcium start leaking into the cell. So because of this, the dopamine vesicles are started releasing out of the cell. So because of this hypoxia, you can see hypoxia inhibits oxidative sensitive potassium channel. Increase of potassium within the glomus cell lead to depolarization, open calcium channel, release of dopamine, and increase. So because of release of dopamine, there is increased hydrogen ions in the common stimuli. Oh, not that one. This is another point. Actually, increase in hydrogen ions is a common stimuli for both central and peripheral chemoreceptors, and common stimuli to activate both chemoreceptors is nothing but increase in hydrogen ions, or also you can see fall in pH, or also decrease in blood pressure. So all these three may be the reason of common stimuli for both central and peripheral chemoreceptor. So actually there is a state called asphyxia. In asphyxia, we can see the three states like hypercapnia or hypercarbia along with acidosis, and also you can see the hypoxia. So these three states together, if it is present, that is called asphyxia. So when chemoreceptors are activated, they try to produce a chemoreflex, and the effect of chemoreflex is always hyperventilation. So because of hyperventilation, the rate and depth of respiration both increases. And next we have hypoxia. Hypoxia, it's a fall in partial pressure of oxygen levels, and this is mainly determined by dissolved form of oxygen, that is partial pressure means dissolved form of oxygen. So we have different types of hypoxia like hypoxic hypoxia, anemic hypoxia, and last two are stagnant hypoxia and histotoxic hypoxia. So first let us discuss the hypoxic hypoxia. So this hypoxic hypoxia is nothing but the fall in partial pressure of oxygen level, especially dissolved form. So it is caused especially in high altitudes. If you go to high altitudes, oxygen level drops. So hypoxia is less dissolved oxygen. So even the peripheral chemoreceptors are stimulated. So because of this, the treatment you can give here is oxygen therapy. And is anemic hypoxia. Here it is seen in anemic patients and also in carbon monoxide poisoning. So actually here the red blood cells are decreased. So even here hemoglobin within them is decreased, and even oxygen content of blood is decreased. So this dissolved form is normal, but the peripheral chemoreceptors are not stimulation. So whenever the dissolved form is normal, you understand the chemoreceptors may not get stimulated, but whenever the dissolved form is altered, then they may get stimulated. So in the case of anemic hypoxia, as dissolved state is normal, they will not get stimulated. And next you have stagnant hypoxia. So stagnation of blood in the tissues, and the name itself we can say stagnate. So because of stagnation of blood in tissues, more oxygen consumption by tissues. So lastly, as more oxygen is consumed, no more oxygen is present now. So the veins have reduced oxygen. So arteriovenous oxygen difference is increased here, because you can see in the vein now it is very low oxygen, whereas in arterial side very high oxygen. So if you make difference between them, it will increase. And cyanosis also occur in this type. Cyanosis means the body gets blue in color because low oxygen, and this is also called as ischemic hypoxia. So another name of stagnant hypoxia is ischemic hypoxia. And next you also have histotoxic hypoxia. So this is mainly seen in cyanide poisoning. It's a defect in oxygen utilization. So because of cyanide poisoning, oxygen cannot be utilized by tissues. Cyanide, because inhibits the cytochrome oxidase, this tissue is affected, can't utilize oxygen. And here also arteriovenous oxygen difference is decreased. So you can see in stagnant hypoxia it is increased, but here it is decreased, because here the tissues is having now low oxygen, and peripheral receptors are also stimulated here, because there is very low oxygen in tissues. So these are all overview of revision series of neural and chemical regulation. So by this we complete our complete revision series of respiratory physiology.